catch it.
Absolutely. Yeah, no, feel free to unmute and Dean and I will be watching the chat as well. But without further ado, I'll let you take it away.
Great. All right. Let me share my screen. All right. So thank you for that introduction and for inviting me to speak today. I'm excited. So I think this won't be new information to any of you, but a little bit of background. So Alzheimer's disease is very common. About 1 in 9 Americans over the age of 65 has Alzheimer's disease. And age is the biggest risk factor. So as the population ages, the total number of people living with Alzheimer's disease is increasing as well. And Alzheimer's disease is one of the top 10 leading causes of death in the US. And it's very expensive. Medicare and Medicaid costs are projected to increase to over $700 billion by 2050. And again, as a little bit of an introduction, so Alzheimer's disease is characterized by the presence of beta amyloid and phosphorylated tau. And the cognitive trajectory for someone with Alzheimer's disease is very different from the trajectory of normal aging. So as you can see in the figure on the right, with that dashed line at the top, everyone has some changes in thinking and memory as they get older. In Alzheimer's disease, that trajectory is quite different. So people develop mild cognitive impairment characterized by greater than expected difficulties with memory and thinking for their age, which progresses to dementia, in which problems with cognition become severe enough to interfere with daily activities and independence. And we know that these proteins begin to accumulate decades before the onset of clinical symptoms. So people are beginning to develop pathology without any overt clinical symptoms. And there is a well-established sex disparity in Alzheimer's disease prevalence. So of the over 7 million Americans living with Alzheimer's disease, nearly 2/3 of them are women. And women have about double the risk of developing Alzheimer's disease compared to men. So a woman at age 65 has about a 20% chance of developing Alzheimer's disease in their life. A man has just over a 10% risk. And the reason for this difference is not entirely clear. There are a couple of possible options that are not mutually exclusive. So women typically live longer than men, and so they have a higher likelihood of reaching the age where Alzheimer's disease becomes more common. So there may be an overall survival advantage. Women may live longer after being diagnosed with Alzheimer's disease, which could also contribute to the observed higher prevalence of Alzheimer's disease in women. Women may also just have an increased risk of developing Alzheimer's disease. And even if that risk is the same in men and women, it's possible, and I think probable, that women have different or unique risk factors for Alzheimer's disease and related dementias. And understanding this sex difference, I think, is important because the field has entered a new era of disease-modifying therapy with a goal of kind of personalized medicine. So these new disease-modifying therapies are indicated for the treatment of mild cognitive impairment and mild dementia due to Alzheimer's disease. And although these trials were not designed or powered to look at sex differences, subgroup analyses do suggest that there may be sex differences in response to these treatments. So lecanemab is one of the 2 FDA-approved drugs that is currently on the market. And you can see that there is a statistically significant effect of these drugs on cognitive outcomes in men, but this is less clearly so in women. And this sex difference was also seen in aducanumab, the first FDA-approved drug that is no longer on the market. The third drug, donanemab, doesn't show the same sex difference that these 2 drugs have shown in subgroup analyses. And so the jury is still out on whether women will benefit from these drugs in the same way that men do when used in clinical practice. But I think it highlights that understanding sex differences in risk factors and disease presentation is clinically meaningful and important if we want to find effective treatments. So I've talked to you about Alzheimer's disease, which falls under the umbrella of neurodegenerative diseases that cause cognitive impairment. But there are also plenty of reversible or transient causes of cognitive impairment that, when addressed, can improve cognition. And these include things like poor sleep, depression and anxiety, certain medications, certain medical conditions, alcohol use. And I think one that doesn't necessarily get a lot of attention, or that we don't necessarily think about, is menopause and menopause-associated cognitive symptoms. So menopause is the permanent cessation of menstruation resulting from the loss of ovarian follicular activity. And this can occur naturally or can be artificially induced through medical interventions that stop ovarian function. And these are things like surgical removal of the ovaries, chemotherapy or radiation, and certain medications. The menopausal transition, or perimenopause, occurs after the reproductive years but before menopause, and is characterized by irregular menstrual cycles, endocrine changes, and symptoms like hot flashes and night sweats. And the majority of women in the US experience perimenopausal symptoms. And a lot of these are neurological. So hot flashes are the most common, but 40 to 60% of women will report cognitive symptoms like forgetfulness during the menopausal transition. Other symptoms like mood changes and sleep disturbances, I think, are worth noting that they can also contribute to cognitive dysfunction as well. So what's the significance of these cognitive symptoms, and what are the long-term effects? So broadly speaking, most cognitive symptoms during the menopausal transition are not due to a neurodegenerative disease. Subjective symptoms that women report are not always associated with objective impairment on neuropsychological testing. When there is impairment, the cognitive domains that seem to be most affected are verbal learning and memory. But typically these are relative weaknesses, so scores often remain within normal limits. And it seems that scores rebound post-menopause. Despite the fact that cognitive symptoms are common during the menopausal transition, there are limitations to the work that has been done. So some of these studies have had relatively small sample sizes. Oftentimes studies that are focused on women during the menopausal transition, cognitive symptoms are not their kind of primary focus, and so they often will have limited neuropsychological tests performed compared to the studies of aging that we're more familiar with. And there also, these studies often have a relatively short follow-up time. So women on average in the US go through menopause at age 51, but we know that cognitive symptoms due to neurodegenerative diseases typically don't develop until women are in their 70s or 80s. And so it's difficult to follow women for such an extended period of time. Even if the symptoms that women are experiencing during the menopausal transition are not the result of a neurodegenerative disease, there do seem to be changes in the brain that are occurring during this period. So vascular risk factors are commonly thought to be a driving factor of white matter disease in the brain. And we know that there's an association between white matter disease and cognitive impairment. And while vascular risk factors like diabetes, smoking, high blood pressure are certainly important contributors, I think they're not the entire story behind white matter disease. So postmenopausal women seem to have a greater burden of white matter hyperintensities than premenopausal women or men. In the figure on the left, there's no sex difference when comparing premenopausal women to age-matched men. And in the figure on the right, postmenopausal women have a greater burden and accumulation of white matter hyperintensities compared to men. The white matter disease that you see on an MRI represents macrostructural changes. There are also microstructural changes that can affect cognition and are thought to often precede those macrostructural changes. And this is a picture that's showing you just that there are lots of different white matter tracks in the brain that are connecting various parts of the brain. And some of these tracks seem to be more vulnerable to changes in Alzheimer's disease. Given the differences in sex differences in white matter hyperintensities, I was interested in understanding whether there are sex differences in white matter microstructure. And to do so, I looked at harmonized data from 9 cohorts of aging that included nearly 5,000 participants. And we looked at various measures of white matter microstructure, including FA, which is a measure of microstructural organization. Models were adjusted for age, race and ethnicity, and ApoE4 status. And I'm showing you here a subset of the 48 white matter tracks that we looked at, but the results here are pretty similar to the results that we in other white matter tracks. The differences were pretty diffuse. And so each of these tracks with a star is showing significant sex differences, with women showing lower FA compared to men, which we oftentimes consider to be a marker of worse white matter microstructure. And we didn't look at these differences by menopause status, although that would be interesting to do. But I think it does, this and other data suggest that there are sex differences in white matter. And I'm interested in understanding what factors drive the accumulation of white matter disease and what is contributing to these sex differences. So this is a graph that's showing you changes that occur pre, during, and post menopause. And estradiol, shown in the orange line, significantly declines during menopause when amyloid, shown in the green line, begins to accumulate. And so loss of estrogen has been hypothesized to play an important role in women's vulnerability to Alzheimer's disease and related dementias. And as I mentioned earlier, the neuropathological changes in Alzheimer's disease begin well before the onset of clinical symptoms. And so the time when neuropathology begins to accumulate for many women can be right around the time of menopause. Work from others have looked into more detail about kind of the biological changes that occur during this time that could be contributing to the development of ADRD. And so there have been animal studies that have shown that there's a shift away from glucose as an energy source in the brain, shown in that solid red line, towards the use of fat as an energy source, shown in the black line increasing, driven by the breakdown of myelin, resulting in white matter degeneration. And so the figure on the right is suggesting that as estrogen declines, there is a shift away from glucose metabolism and an increase in amyloid deposition and white matter degeneration, which results in an increase in ADRD risk. And the figure on the left is also showing that there are changes in immune response and function. And the role of inflammation in the development of and propagation of ADRD pathology is a series of talks for another day, but there's, I think, increasing evidence for a role of immune processes in the pathogenesis of ADRD and an interest in developing therapeutics that target neuroinflammation. So I was interested in looking to see whether neuroinflammation relates to white matter hyperintensities and whether there are sex-specific effects. To do so, I used the Vanderbilt Memory and Aging Project, which is the signature cohort of the Vanderbilt Memory and Alzheimer's Center. VMAP is a longitudinal observational study that began in 2012 at Vanderbilt, and the overarching goal of VMAP is to assess cardiovascular contributions to cognitive and brain health in aging prior to the onset of clinical dementia. And in addition to the cardiovascular measures, participants complete comprehensive neuropsych testing, blood work, clinical questionnaires, MRIs, and an optional lumbar puncture for cerebrospinal fluid collection. So 335 participants were enrolled in 2012 who were 60 years of age or older, free of clinical dementia, stroke, or heart failure at study entry. And about half of participants consented to a lumbar puncture, which is completed at each study visit. So we used cerebrospinal fluid YKL-40 as a marker of neuroinflammation, and then looked at white matter hyperintensities. Models were adjusted for age, sex, race and ethnicity, education, the Framingham stroke risk profile, body surface area, cognitive status, and ApoE4 status. And linear regression models were used for cross-sectional outcomes and mixed effect regression for longitudinal outcomes. And we used a sex by YKL-40 interaction term, and models were stratified by sex as well. So cross-sectionally and longitudinally, there was no association between YKL-40 and white matter hyperintensities. However, YKL-40 interacted with sex in both cross-sectional and longitudinal white matter hyperintensity outcomes. And here I'm showing you that there are significant cross-sectional interactions. So you can see that in women, YKL-40 related to whole brain white matter hyperintensity burden, as well as frontal lobe white matter hyperintensity burden. And in and this was not the case in men. And in stratified analyses, YKL40 related to whole brain, frontal, as well as parietal, temporal, and occipital lobe white matter hyperintensity burden. In longitudinal models, YKL40 interacted with sex on the temporal lobe white matter hyperintensity burden. So you can see here, greater YKL40, indicative of greater neuroinflammation, was associated with and the change in temporal lobe white matter hyperintensity volume over time in women, but not in men. And in women, only the temporal lobe outcome survived correction for multiple comparisons, but YKL40 was also related to whole brain and parietal lobe white matter hyperintensities. So it seems that in women, neuroinflammation related to white matter hyperintensity burden, but that was not the case in men. Another interesting possible contributor to white matter hyperintensities is vasomotor symptoms, which are a sex-specific risk factor. So vasomotor symptoms are night sweats and hot flashes that women commonly experience during the menopausal transition. And this was a study that looked at vasomotor symptoms and white matter hyperintensities and found that there was an association between the two. And that was not accounted for by other covariates like cardiovascular risk factors. And so this data suggests that vasomotor symptoms could be one reason why women have an increase in white matter hyperintensities post-menopause. And so we know that white matter hyperintensities can relate to cognitive symptoms. And so a question that arises then is whether this association that we're seeing here is clinically meaningful, whether we will see cognitive effects of a relationship between vasomotor symptoms and cognitive outcomes. The studies that have looked at the relationship between vasomotor symptoms and cognition are mixed. So most of them have been cross-sectional and have found varying results. So some suggest that there's worse verbal memory associated with greater vasomotor symptoms, slower processing speed, worse attention. Others have found no association at all. There have been fewer studies that have looked at the longitudinal trajectories. And there's been one that found an association between vasomotor symptoms and forgetfulness, and another that found no change in cognition. But again, these studies have had relatively limited long-term follow-up. And so I was interested in understanding if vasomotor symptoms related to later life cognition. So to try to answer this question, I used data from the Wisconsin longitudinal study. This was a study that began in 1957 that included a third of all high school graduates, so just over 10,000 participants, who had graduated from high schools in Wisconsin in 1957, and they have been followed longitudinally. Beginning in the 90s, surveys started to cover health and cognition. So women were asked about vasomotor symptoms at age 54, and then they had cognitive testing at age 65 and 72. And these participants are almost exclusively non-Hispanic white. So we were looking at vasomotor symptoms, and then the outcomes were various cognitive tests. So similarities, letter fluency, word recall, and digit ordering. And we used nested models that adjusted for early life socioeconomic status, reproductive characteristics, hormone therapy, and midlife income. And you can see here that the results looking at cognitive testing, first at age 65 on the left. And these are the beta estimates with results broken down by each cognitive test. The estimates in light gray are the unadjusted models, and the black are adjusted. And you can see that in the unadjusted models, higher vasomotor symptom score was very modestly associated with a lower similarity score, but no other cognitive test outcome. And in the adjusted models, there was no association between vasomotor symptoms and any of the cognitive tests. When looking at change in cognition from age 65 to 72, there was also no significant association both in the unadjusted and the adjusted models. There was not a big change in scores on cognitive tests from age 65 to 72, and the average change in score did not differ by tertile of vasomotor symptom severity. I think it's worth noting that all of the participants in the study had at least a high school education, and people with more education have more cognitive advantage. They perform better on testing and can tolerate neuropathology. And so these are some of the reasons why we may not have seen a large decline in testing over time. It may be that these participants were also too young to be experiencing significant cognitive decline. And so were we to look at these women again in their 80s, perhaps we'd see something different. And so I don't think this settles the question of how the kind of effects of vasomotor symptoms, but it provides some evidence that subjective vasomotor symptoms don't impact cognition in women in their 60s or early 70s. So this is the graph that I showed you before, looking at changes in hormone levels and Alzheimer's disease neuropathology across the menopausal transition. And we've talked a little bit about how some of these changes seem to occur during menopause and how they may relate to ADRD risk. Looking kind of specifically at estrogen and its kind of possible pathways by which changes in estrogen can affect health. So changes in the vasculature are another way by which menopause and loss of estrogen could impact ADRD risk. There's a well-established connection between vascular health and brain health. We know that overt vascular disease like strokes affect cognition, as do vascular risk factors like hypertension and cigarette smoking. My colleagues at the Vanderbilt Memory and Alzheimer's Center have shown that even subclinical changes in cardiac function, such as asymptomatic reduced cardiac output, are associated with differences in brain health. This is a figure showing you cardiac index, which is comparable to cardiac output, but accounts for body surface area. And this is showing you that cardiac index relates to lower cerebral blood flow in the temporal lobes where Alzheimer's disease pathology first develops. And the group with the highest cardiac index, shown on the right, had greater cerebral blood flow relative to the group with the lowest cardiac index on the left. Our group has shown that reduced cardiac output relates not to just reduced cerebral blood flow, but presumably the downstream consequences of reduced blood flow, including neuroinflammation, atrophy, and cognitive decline on neuropsychological testing. Despite the fact that women are disproportionately affected by Alzheimer's disease, we don't know how sex modifies the relationship between cardiac output and abnormal aging. So I was interested in looking at whether cardiac output relates to spinal fluid, amyloid, or tau, core AD biomarkers, and whether sex modifies this relationship. And to do so, I again used the Vanderbilt Memory and Aging Project, which I mentioned collects all of this data, including cardiac imaging like echocardiogram, as well as that optional lumbar puncture. Cardiac output was assessed by the echocardiogram performed at study entry, and the amyloid and tau were the outcomes of interest. And again, models were adjusted for age, sex, race and ethnicity, education, the Framingham stroke risk profile, body surface area, cognitive status, and ApoE4 status. And we also included a sex by predictor interaction term, and then models were stratified by sex. In secondary analyses, we looked at stroke volume and heart rate, which are the components of cardiac output as predictors as well. So we found no association between cardiac output and either amyloid or tau cross-sectionally or longitudinally. In longitudinal analyses, there was a significant cardiac output by sex interaction for amyloid. As you can see here, lower cardiac output, shown on the left, was associated with a decrease in amyloid over time in women, but not men. And as amyloid accumulates in plaques in the brain, the levels of amyloid in the spinal fluid decrease. And so this suggests that that decrease in amyloid over time is suggestive of amyloid accumulation in the brain. There was no significant sex interaction for p-tau and no association in males or females. When we looked at stroke volume and heart rate, the components of cardiac output, you can see that stroke volume interacted with sex on amyloid levels. So again, in the figure on the left, you can see that lower stroke volume was associated with a decrease in amyloid over time in women, but not men. Heart rate did not interact with sex on amyloid levels. Importantly for this study, we know that estrogen is vascular protective. Studies have demonstrated that postmenopausal women exhibit lower cardiac output compared to premenopausal women, and that estrogen therapy may increase both stroke volume and cardiac output by promoting vasodilation and favorable cardiac remodeling. So the decline in estrogen that occurs during menopause may lead to sex-specific cardiovascular changes that disrupt cerebrovascular hemodynamics and promote amyloid accumulation in women. Interestingly, we did not find that cardiac output related to p-tau. Others have shown that tau burden is greater in women than men, but importantly, this seems to occur in the presence of amyloid pathology. And so this figure is showing you that tau, in purple, begins to accumulate after amyloid, shown in blue. And the majority of participants included in this study were cognitively unimpaired. So it may be that our participants were just not far enough along on that Alzheimer's disease path, and had our sample included participants with more advanced disease, perhaps we would have seen a relationship with p-tau. If the biological changes that occurred during this time start you on the process of developing pathology, then earlier age at menopause could lead to a longer time for this pathology to accumulate, and thus greater risk of developing clinical symptoms. Artificial menopause, which by definition occurs before natural menopause, could relate to ADRD risk in the same way. But there are also other factors like the abrupt loss of estrogen that occurs with artificial menopause, as opposed to the more gradual decline that occurs with natural menopause, or social factors related to why women are undergoing artificial menopause that could be influencing ADRD risk as well. So studies have looked at the relationship between age and type of menopause and cognition. So this is a study from the ROSMAP cohort at Rush. And this is looking at slope of cognitive decline over time in women who've had natural menopause, which is the red line, and surgical menopause at varying ages, with that orange line being the oldest age of surgical menopause and getting progressively younger up until that blue line. And they found that earlier age at surgical menopause is associated with a steeper slope of decline during the study, as well as a lower intercept to begin with, which they argue suggests a substantial amount of decline had occurred prior to study enrollment. Earlier age at surgical menopause was also associated with a higher burden of global measures of AD pathology. There was no relationship between age at natural menopause and any of the neuropathological outcomes. People have also looked at the relationship between oophorectomy, so surgical removal of the ovaries, and cognitive impairment and dementia. This was a study that came out of Mayo, and looking at women who had undergone either unilateral or bilateral oophorectomy before the onset of menopause, compared to age-matched women who had not. And they found that there was an increased risk of cognitive impairment or dementia for women who'd undergone either of these procedures. And this association was stronger in the earlier the surgery had taken place. So these previous studies had looked at global cognition and all-cause dementia. I was interested in looking at whether age at onset of menopause and hysterectomy status related to clinical AD specifically. So I also used the ROSMAP cohort as well as the MARS cohort at Rush. And this was a group of just under 3,000 women. And you can see here that hysterectomy status was not related to time to onset of Alzheimer's disease. Compared to women who had not had hysterectomy, women who'd had a hysterectomy were not at an increased risk of developing Alzheimer's disease. However, participants with an earlier age at menopause had a faster time to AD onset. And compared to women who had menopause after age 50, women who had menopause before the age of 45 had an increased risk of developing Alzheimer's disease. Although this was not the focus of our study, we were also interested in looking at whether hormone therapy use impacted Alzheimer's disease risk in this cohort. And you can see here that for women with the earliest age of menopause onset, the association between age at menopause and Alzheimer's disease risk persisted in those who had not used hormone therapy, but in those who had used hormone therapy, the association was no longer significant. And hormone therapy use continues to be an ongoing area of interest in terms of its effects on brain health, and the relationship seems to be complex. And our understanding of the impacts of hormone therapy have kind of evolved over the past 30 years or so. So initial observational studies showed that hormone therapy seemed to be beneficial during the menopausal transition. So this was a meta-analysis that suggested that hormone therapy use was protective against developing Alzheimer's disease. This thinking changed pretty dramatically in the early 2000s with the results of the Women's Health Initiative clinical trial. This was a clinical trial that enrolled women who were postmenopausal, who were 65 years of age or older, and either were randomized to the hormone therapy group or the placebo group. And you can see here that unlike the observational studies, women who were in the hormone group showed a significantly greater hazard of developing dementia compared to those who were in the placebo group. This study was criticized because these women were likely not representative of most women being prescribed hormone therapy, who are typically closer to the age of menopause and are symptomatic. Nonetheless, prescribing practices changed dramatically. So women were much less likely to be prescribed hormone therapy, and that has kind of persisted over the past several decades. However, follow-up studies have not found that hormone therapy use, when given to kind of a subset of women, have the kind of negative impact that was seen in the WHI study. So this is a clinical trial of women who were in their 40s and 50s, who were within 3 years of menopause and who did not have heart disease. And cognition was not their primary outcome of interest, but after 4 years of follow-up, there was no association between hormone therapy use and cognition. And this figure here actually is looking at various cognitive domains and is a follow-up study that took place about 10 years after completion of the main trial. And you can see here that there isn't a difference in performance between hormone therapy users and non-users. Earlier in November, it was announced that the labels for hormone therapy use were going to be revised with age-specific guidance. And the cognitive effects of hormone therapy are just kind of one piece of the puzzle. But I think it'll be interesting to see what the practical implications of this are and whether there are changes to prescribing practices as a result of this change. So I have told you about the Memory and Aging Project. The Tennessee Alzheimer's Project, or TAP, is the clinical cohort for our ADRC. And because of my interest in women's health, we've implemented a reproductive health module in both cohorts that asks women about things like pregnancies, hormonal contraception use, menopause characteristics, as well as menopausal hormone therapy use. And so I'm hoping to be able to leverage this reproductive module for my future work. Amyloid and tau are obviously two important components of abnormal brain aging, but exploring concomitant pathways of injury like neuroinflammation and white matter disease and downstream consequences like cognition, I think, are also important. And VMAP has this really rich information on vascular hemodynamics, and so I'd like to try and understand whether factors that impact hormone exposure, like age at menopause and hormone therapy use, modify the relationships that we've seen between vascular changes and brain health in women. And kind of throughout this talk, I've hypothesized that changes in estrogen levels during menopause are driving these brain changes. And so I'd like to be able to look both at exogenous hormone therapy use, but also endogenous hormone therapy levels to understand what impact that has on the brain. Um, and that's both estrogen, which gets a lot of attention, but also progesterone levels change during menopause, and the relative ratios of these hormones to testosterone also change. And so I think there's still a lot to learn about menopause and hormone changes specifically and their effect on the brain. So with that, I will thank you for your attention, and I'm happy to answer any questions or have a discussion.
Thank you so much. This was awesome. Yeah, I'll open up the floor. If anyone has questions, feel free to put them in the chat, unmute, whatever works best for you.
Thank you so much. I really enjoyed that talk. I can lead us off maybe with a question here. But something I'd love to kind of think about was it really kind of was, eye-opening to me thinking about, earlier menopause and artificial menopause and how that can lead to ADRD symptoms. So I'm kind of wondering a little bit about like people maybe with the BRCA1, BRCA2 gene who often are recommended, to get a hysterectomy. But what that might mean if you get it maybe at 30 years old to potentially leading to ADRD symptoms. So I'd just love to hear kind of your thoughts on that. Maybe if there's like a middle ground, kind of just, yeah, what your thoughts are.
Yeah, I think so. I'm not an OBGYN, so I can't say this for sure, but I think in general, those women now are often prescribed hormone therapy immediately after the surgery to try and kind of continue that hormone exposure till the age that they would go through natural menopause. And I think that's supported by some of the data that's out there. So the study that I showed you from ROSMAP that looked at global cognitive trajectories, the women who'd undergone surgical menopause who'd been given hormone therapy, that seemed to improve their cognitive trajectories. So um, I think that's probably what the evidence would suggest. And I think the studies that have looked at surgical removal of the ovaries, oftentimes they're for benign indications, but I think that when they've looked at kind of different indications, there hasn't been a difference kind of based on what the indication for the surgery is.
Awesome. Awesome. Thank you, Dr. Peterson.
Yeah.
I thank you for this very interesting talk. I wonder if there is much literature about hormone replacement therapy and white matter hyperintensities. Are you aware of such studies? Are you planning to do those?
Yeah, I'm interested in looking at hormone therapy use and white matter hyperintensities, as well as the kind of white matter microstructural changes. I imagine there's some literature out there that has looked at that. I'm not as familiar with that data.
Thanks.
I was wondering if you could share the questions or like the questionnaire that you use to collect women's health information. Is that like beyond what the UDS4 is getting? It sounds like you're collecting more detailed information than just like age of menopause.
Yeah, we've tried to harmonize we had been using a questionnaire that we kind of based off of ROSMAP and the Women's Health Initiative questionnaires that they asked. We harmonized it with the UDS4 data. So I think we asked some additional questions, but they're very similar to what's asked in the UDS4.
Okay.
And I haven't done any research in this, but another area that has gotten some attention lately is adverse pregnancy outcomes. And we don't ask about that right now in our questionnaire, but that would also be something that I'd be interested in adding that I don't think is in the UDS4 questionnaire, but seems kind of things like preeclampsia and gestational hypertension and gestational diabetes seem to potentially have an impact on cognition later in life. So I think that's a underexplored area.
Yeah, definitely.
Awesome. Anyone else with some last questions? Otherwise, we can always end a few minutes early. And I'll make sure to get the recording out to everyone who's not able to watch it as well, because this was very informative and I have a lot of people that want it, so I'll make sure to post it online for everyone.
Does heredity play a part? I get
What do you mean by that?
inheriting the disease from a family member, your mother, perhaps.
I don't know if they have looked at kind of sex differences in terms of family members and relative risk of developing Alzheimer's disease in the children of those of parents. And I mean, there's lots of genetic work, I think, going on looking at sex differences in terms of like resilience and things like that, and specifically looking at like the X chromosome. So I think there are sex differences in terms of genetic risk for developing Alzheimer's disease, but there's still more work to be done in that area.
Thank you.
Okay. Any last questions from anyone on the Zoom? Okay. Well, thank you so much, Dr. Peterson. This was an amazing talk. We really appreciate you coming, and we look forward to staying in touch and seeing what else you publish out there. And yeah, I just want to thank everyone for coming, and I hope everyone has a great rest of their day.
Thank you very much for having me.
Thank you so
Thank
much.
you.
Have a great day, everyone.